Hey Gail, can you hear me?
I can.
Yes, I can.
Can you can you record as well just in case for backup, please?
Yeah, no problem.
Thank you. Yeah,
Yeah.
thank you.
Hi, Kara and Gail and everybody.
Hello.
Hello.
Here I have 1 o'clock. Do you want to get started or wait another minute or so?
Really chiming in, but I say let's go ahead and get started.
Okay. Well, hello and good afternoon. I'm Joanne Bolick, and I'm a consultant for Heartland. And I want to welcome you to the third in a series of the Heartland Regional Genetics Newborn Screening Echo Series. Our series is entitled Helping Babies Get Off to a Good Start. The purpose of the Echo Newborn Screening Series is to address the educational needs of the newborn screening community. 3 newborn screening conditions were selected based on 2 surveys that were sent out and input from the Heartland Regional Network leadership, as well as the Heartland Echo Hub team that we formed. And we selected 3 newborn screening conditions. The first one was on newborn screening for congenital hypothyroidism, which we offered in January. We offered a second newborn screening series on cystic fibrosis, and that was offered in February. And today's talk will be on newborn screening for mucopolysaccharidosis type 2, or better known and easier said as MPS 2, and it's going to be provided by Linda Manwaring, a genetic counselor in Missouri. MPS 2 is a new condition that only a few states are offering, and it's a mighty disorder. Lots of things to learn about it. In case you're wondering what ECHO stands for, it stands for Extension for Community Healthcare Outcomes, and was created over 20 years ago by Sanjay Arora, a gastroenterologist at the University of New Mexico Health Sciences Center, for the purpose of promoting and creating access to healthcare for patients within the community. We have no disclosures. It's the next slide. I will go down to it maybe. From either our speaker today or from members of the hub team. We have no disclosures to provide. Also, we're offering free CEUs for physicians, physician's assistants, nurses, and genetic counselors. And you must be here at an attendee at the meeting in order to receive that. Oh, and genetic counselors. and complete an evaluation. We will have all three of these presentations on the Heartland website for you to watch, but there are no CEUs associated with watching them just there. The next slide is on members of the hub team that helped coordinate and putting all these trainings together. And as I said, I'm Joanne Bolick, and I'm a facilitator for the coordinating the newborn screening series. The ECHO training emphasizes an all teach, all learn approach. We have a brief introduction, which is what I'm doing right now, and it's followed by a didactic session and case presentation. There's a lot of question and answer, interactive discussion. This interactive venue, promotes learning experience for all. And it's case-based and promotes best practices. In the last few minutes, after we end this, will be some closing remarks. I want to offer all the participants the ability to introduce themselves by typing in the chat box their name, title, organization, and state where they are from. I'm going to introduce the speaker now, but first I also want to tell you that if you have any questions that come to mind and you would want to ask them, put them in the chat box so you don't forget them, and we can be sure and tell Linda after she finishes the didactic session, and we can address those. Now let me introduce Linda Manwaring. She's a genetic counselor with the Washington University St. Louis School of Medicine, Department of Pediatrics in the Genetic and Genomic Medicine in St. Louis, Missouri. In 1996, she received her Master of Science in Genetic Counseling from the University of Pittsburgh. Linda is a certified genetic counselor by the American Board of Genetic Counseling, and she's licensed in Illinois as a genetic counselor. In 2013, Linda implemented and coordinated newborn screening for lysosomal storage disorders for the St. Louis Children's Hospital in St. Louis, Missouri. According to the New Steps website, Missouri is one of only 4 states, along with Pennsylvania, West Virginia, and Illinois, that perform newborn screening for MPS 2. Lastly, I want to offer you the ability, if you want to, during the session, you can turn off your video if you would so like, or you could leave it on. Now I want to turn over the time to Linda so she can start her presentation.
Thank you. I am going to quickly take a second to share my slides here. And it's not going to full screen for me. There it goes. Okay, can you all see that then?
Yes.
Perfect. So I have nothing to disclose, as Joanne had said. So the objectives for this, I was asked to speak on Missouri's with newborn screening specifically for MPS 2. We're going to review the features of MPS 2. We're going to talk about what Missouri does in terms of newborn screening. We're going to discuss the treatment options that are available currently for MPS 2, and then I have a couple of case examples at the end just to facilitate some discussion and some of the complexities that we have encountered with these patients and babies that we're seeing and through our clinic. You can't talk about MPS disorders, the mucopolysaccharides, without talking about lysosomes. And I know this is a diverse audience, so we're going to just define some terms as we go throughout this lecture, just to make sure that we're all, on the same page with the same background. So lysosomes really are the digestive system of the cell, and they're breaking down the proteins, the carbohydrates, the lipids that come into the lysosome. And so with the lysosomal storage disorders, it's a group of inherited metabolic disorders. And it's a rather large group of conditions, but they're all characterized by the accumulation of various states within the different organs of an individual that are due to a deficiency of a particular lysosomal enzyme. Individually, each of these disorders are quite rare, but as a group, we think that they, are roughly 1 in 5,000 live births. So as a whole and in total, they're actually a pretty significant chunk of patients that we come across within our clinics. And they're really characterized because they're multisystemic, they're progressive, and then without intervention, these patients, have a lot of morbidity and mortality associated with their disease. This slide was developed by one of our physicians, and I think it's a great analogy. So on the left, you have the healthy lysosome. And if those of you who are old enough to remember the old school Pac-Man game, the lysosomal enzyme is acting as that Pac-Man, and it's chomping down and eating up and digesting all the substrate within the lysosome. Without the Pac-Man, without that enzyme present, the substrate just accumulates within the cell because there's nothing to eat against it. And that ends up causing enlargement of the lysosomes, and then ultimately also enlargement of the organs as you get accumulation of that substrate. So this would be a picture of an actual cell without the Pac-Man, of course. And so you can see on the right-hand side, you have all those white spaces, and those are the lysosomes. And you can see compared to how they look on the left, they're obviously enlarged. And that is from the lack of whatever the lysosomal enzyme is for this particular disorder. The other thing with lysosomal storage disorders, which makes them, I don't want to say tricky, but can make their treatment complicated and more complex, is that they don't all present the same. Even if you have a child who has MPS II, there's gradations and variation in what you can see. So if you talk to someone in genetics, well, you'll often hear us talk about severe versus attenuated, and attenuated meaning later onset. So, I have the two arrows there where the severe and attenuated, or earlier, later onset. And some people also refer to them as neuronopathic or non-neuronopathic, meaning, does it involve the brain? Does it cause intellectual disabilities or developmental delays? So these are all terms that we talk about within our clinic and within our patient population. And it can make sometimes how we think about treatment a little bit more complex because we don't always know exactly how a patient may present based upon the information we have on hand. So the mucopolysaccharides, just like the lysosomal storage disorders, are a group of disorders. They're collectively referred to as the mucopolysaccharides. As Joanne said, MPS is a whole lot easier to say, so we do usually refer to them as MPS disorders. Again, they're characterized by lysosomal enzyme deficiencies, and you get tissue storage of a substrate which we call mucopolysaccharides. We often refer to them as glycosaminoglycans or GAGs. Sometimes you might see them still referred to as MPS. But there are currently 11 enzyme deficiencies representing 7 different MPS disorders. And the deficiency in those enzymes can lead to that GAG accumulation. And did that just click off, or is that just on my screen that something moved? Okay, you're still fine. Okay. Okay. And so, like I said before, they're a progressive disorder with multisystemic involvement. Just to define some terms, the MPSs are due to the fact that they're long chain of sugar molecules. And so the name muco just refers to the thick consistency of the molecules. Poly obviously is many, and saccharide is that sugar molecule. And I already explained that they're also called glycosaminoglycans. When you see a report, the glycosaminoglycans are often broken into 4 main categories: the heparan sulfate, chondroitin or dermatan sulfate, keratin sulfide, and then the hyaluronan. And so you'll often see them broken up, and you can get reports that reflect the total GAGs, or you can see them that indicate the individual components. And the individual components can help you think sometimes about what particular MPS disorder you might want to have, because they can have different patterns across the different diseases that we see. This is just a slide that is just showing, that the amount of residual enzyme activity is one of the main drivers of clinical severity. And then, like I talked about, that, the elevations of heparin, dermatan, keratin can be reflective of what we're seeing clinically within an individual in terms of what organs tend to be most involved. So this is just a pretty broad picture of various MPS disorders. And if you take a minute just to scan through the images that you see, I think some of them, I think all of us would readily recognize as, something being different. In genetics, we use the term dysmorphic. And so just there being some facial differences with these individuals. But then some of them, I think many of us would be pretty hard pressed to recognize that there's really much different about them. Of course, just some of the spectrum that we can see with this disorder of that early onset, late onset, and also just reflecting the fact that it is a progressive disorder with across the board for all of the MPSs. So this is a general slide talking about the clinical manifestations of MPS in general. So in general, there can be developmental delays and cognitive impairment. There might be communicating hydrocephalus. Carpal tunnel syndrome, spinal cord compression is one of the things that we see and have to pay attention to for patients. Corneal clouding, You can often have conductive and sensory neural hearing loss. You can have pneumonia. You can have frequent ear infections. That's a common presentation for kiddos before newborn screening, is just frequent ear infections. You'll see abnormal gums, abnormal teeth, abnormal enamel, obstructive sleep apnea. You can have heart disease. We'll talk more about the joint stiffness and contractures. The hepatomegaly is a big thing that we notice, and then hernias is a pretty frequent thing that we see as well within our clinic patients. So this would be just some of the facial features that you can see. We describe them as coarse facial features. They're not present at birth. They manifest usually around 18 months to 4 years of age. One of the most noticeable things that you can see is the macroglossia, or the enlargement of the tongue, is something that we frequently see. You also have these prominent supraorbital ridges where you have just, it looks more full above the eyebrow, so to speak. Broad nose and a broad nasal bridge. And then just the deposition of those glycosaminoglycans in the soft tissues can make their cheeks look rather round and their lips look very full. And that's a pretty typical feature that we see across the MPS disorders. And it's not advancing for me. I'm not sure. There it goes. I obviously didn't retitle this slide correctly, but this is just that claw-like hand that you see pretty frequently with MPS disorders. They end up getting stiffness of the hands that limits their mobility and dexterity with the hands. And I've been around long enough that the MPS Society, they've actually changed their logo. So, many moons ago when I first started, the hand was actually their logo, was part of their logo, because it is just such a distinctive feature for individuals who have MPS II or any of the MPSs. The skeletal findings are also important. So it's not uncommon, you'll notice a child who has short stature, and if the physician sends them for x-rays, if it comes back showing dysostosis multiplex, that is indicative of an MPS disorder typically. So what you see often are the generalized thickening of long bones. They can have rounded vertebral bodies. The second picture in that middle one on top shows oar-shaped ribs. That is pretty classic for MPS. And then in picture B on the bottom, you can see that claw hand where they're just not able to open their fingers fully. You also get this gibbous deformity of the spine, which can also be progressive. So we see that in several of our families and patients within our clinic. And so I wanted to actually spend a little bit of time talking about MPS I to set the stage for MPS II, just because we also do newborn screening for MPS I, and they're pretty similar. And so just to talk a little bit about what they are in relationship to one another and how we differentiate them. Treatment is similar, but still just wanted to set the stage so we are all familiar with MPS I as well. So MPS I is due to a deficiency of a lysosomal storage disease enzyme called L-iduronidase. It accumulates the heparin and the dermatan part of the glycosaminoglycan. And about 2/3 of patients with MPS I develop cognitive impairment. And I should say, because I don't think I've said this yet, that MPS I is also referred to as Hurler syndrome, and MPS II is often referred to as Hunter syndrome. And so just to differentiate the two. Typically with MPS I, you're going to see onset of symptoms before 6 months of age in the severe form. And then in that severe form, mortality is usually by 10 years of age for those kiddos. It's rare, estimated incidence of 1 in 100,000, and it's recessive. I don't have a slide on recessive disorder, but both parents are typically carriers. The child would have to inherit both copies of the changed gene to have the symptoms and manifest MPS I. But this would be just, again, showing that severe to attenuated spectrum of what you can see with MPS I. So on the left would be an individual who has the more severe cognitive impairment. They've had more progression. They can have severe respiratory disease, severe airway disease, and death usually before the age of 10. Whereas on the right, you can have individuals with normal cognition. It tends to be less progressive, so less physical problems, but they can still have corneal clouding. They can still have joint stiffness, heart disease, and they will live longer than the individuals who have the more severe presentation of disease. So just to compare and contrast a little bit of MPS II, because you'll find that a lot of it is very similar. So the main thing that we think about with MPS II, aside from the enzyme and the gene that are impacted, is that MPS II typically only impacts boys. There are occasional, very rare reports of affected girls, but because this is an X-linked disorder, it is something that we see impacting the males more than the females. Again, it is due to that accumulation of the heparin and the dermatan sulfate. And just like with MPS I, you have about 2/3 of the patients who have MPS II who are developing cognitive impairment or that neurotic form of the condition. Onset for symptoms is usually between 1 to 3 years of age in the neuronopathic form. And really, it's pretty similar to MPS I. The main thing that you see that's different is there's no corneal clouding in MPS II. And MPS II individuals can have skin pebbling, and I have pictures of what that looks like in a little bit. Incidence, maybe a little similar, maybe a little bit less common than MPS I. So if we look specifically at MPS II, I think what's really hard for families, particularly when we think in the context of newborn screening, is these babies appear completely normal at birth, and their development seems to be coming along and they're doing well. And oftentimes these kids will start to regress with their development. They start to progress with some of the symptoms. And so maybe it's macrocephaly with the hydrocephalus. Some babies will develop the macroglossia. Like I said earlier, those frequent ear infections are something that we frequently see. The hearing loss, the hepatosplenectomy, some rather large hernias, the dysostosis multiplex, and the developmental delay. One of the interesting things is they tend to have a hoarse voice. And so that's something that you'll notice if you enter into a conversation with individuals with MPS II is just a very hoarse voice that they have. With the severe neuronopathic form, you'll have behavioral concerns that manifest. Like I said earlier, regression, spinal stenosis, the carpal tunnel. The joint contractures cause significant loss of mobility, particularly in the hands. And so to sit on this for a minute, it's just interesting to me as I get to know the families that we've worked with over the years. The hand deformity can really be impactful as well as just the joint stiffness, just because it really limits their range of motion and what they can do. And coming up, I have a slide just showing you some of their range of motion. But, it impacts them even in the basic daily functions of life. So, we have a particular patient who in his 20s or 30s at this point has MPS I, but because of the joint stiffness, he is unable to wash his own hair because of the significant stiffness that he has in his shoulder girdle. And so as a result, his family has worked out, they're beautiful in terms of these families are so resilient in terms of coming up with solutions. So what they do is, he and his dad don swim trunks, and the dad will step in the shower to wash his son's hair when he needs his hair washed. And so just, the fact of how creative they are and finding workarounds and solutions to be able to continue on with the things that they need to do. And then that short stature, usually we see starting around 5 years of age. So then I wanted to just spend a little bit of time talking about some of the complications that we can see with MPS II as individuals get older. So the respiratory complications really are significant for these individuals, those frequent upper respiratory infections, because of the accumulation of those glycosaminoglycans in the tongue and in the soft tissue in the oropharynx, you can get narrowing of the airway, which can be complicated for patients. Thickened respiratory secretions can occur. You get stiffness of the chest wall. The hepatosplenomegaly, even pushing up, can all reduce thoracic volume. And so usually this is progressive, usually results in sleep apnea, and eventually patients end up trached within our patient population. From a cardiovascular standpoint, they have valvular disease, they can have cardiomyopathy, hypertension, and this is a major cause for these patients in terms of their morbidity and mortality. Death often occurs in the second decade of life for patients, and that tends to be for the neurological or neuronopathic form. Patients with minimal to no neurologic involvement can reach adulthood. We do have adult patients. Elder variants can and have been reported into the 5th and 6th decade. So this would be just a patient pulled from the literature. You can see the coarse facial features that this individual has. didn't mention, but I tend to think of them as a bit more hirsute, or having a bit more hair on them compared to some other patients. But you can see his broad nasal bridge. You can see that prominent supraorbital ridge and just kind of the more fullness of his cheeks. You see the clawed hands. And then picture C on the right shows just the limitations in his range of motion. Like that is as far as he can get his shoulders up. And so you can see how that would really pose problems in daily life in terms of being able to shower, in terms of being able to reach things on higher cabinets and higher shelves. And so just having to work with these families, we do refer to occupational therapy, but obviously the joint range of motion is going to be a progressive complication and concern for these individuals. I really like this slide because it just really underscores the progression that you can see so impactful within these images. This is all the same child. So from left to right, he's 6 months, and then 5 years, 9 years, and 30 years. And so this would be someone who does not have the neuronopathic form, but it really shows just the clinical progression in terms of the facial features. So I think it really just shows, okay, if this is happening to the facial features, we're also seeing progression in terms of the bone and the cardiovascular and the other manifestations that you can see in individuals who have MPS II. This slide here, I included, you can see on the left, the boy has some of the facial features of MPS II, but the top right picture really underscores or shows you the skin pebbling. It's a little hard to see, but you can sort of get the idea that the skin texture is a little bit different, and the one to the left of it too, the two top pictures, just that pebbling and skin that they have along with the pebble texture. And then the bottom two pictures is just showing you that extra hair that individuals can have across their body with MPS II. This slide here, I just wanted to include because I think it's important to reflect on the inheritance of MPS disorders and to make sure everyone understands, because this is X-linked, we are only seeing the males who are affected. So I have to get my brain around which slide I'm looking at. Starting on the right, I prefer to start on the right. So it would be a mom who's a carrier represented by the blue on her X chromosome. So females have 2 X chromosomes, guys have an X and a Y typically. And so the mother would have one of her X chromosomes that has a change within the gene for MPS II. She has a 50-50 chance of passing that on. Dad is who is going to determine gender of the newborn child. So they have a 1 in 4 chance to have a child who is a son who has the MPS gene that change on it inherited from mother. They also have a 1 in 4 chance to have a daughter who inherited this genetic change as well. On the left would be if a father were to have MPS and how he would pass that on. He would pass it on to all of his daughters and none of his sons. I am sure there are reports somewhere of people who have had children who have MPS II. I am not familiar with them. The patients in our clinic have not had children, so it's not something I am familiar with, but we would expect all of their daughters to be carriers. And then, like I said before, I think that the incidence or frequency is 1 in 100,000 to 1 in, 170,000, somewhere in that ballpark. Again, we're looking at that severe to attenuated or early to late onset spectrum. So like I've shared, and just to remind you all, 2/3 of patients tend to be severe, so early progressive versus slowly progressive. In the severe form, you have the CNS involvement, cognitive decline and regression, versus in the attenuated form, the CNS does not tend to be impacted. In the severe form, there's progressive airway disease and cardiac disease and death really in that first or second decade. Whereas in the attenuated form, you get the GAG accumulation, it's just not as severe. And so they can have survival into their early adult years. The deficiency really does impact the severity of the disease in terms of that enzyme level. So the enzyme is iduronate 2-sulfatase. We do like to point out that there's multiple sulfatase deficiency that can also have low I2S enzyme level. So we do like to have documentation of normal enzyme activity of at least one other sulfatase to make sure that we're diagnosing the correct condition. And then we're looking at the IDS gene. And so hemizygous is just saying for those males, we're looking for a single copy of a pathogenic variant within this gene. We are also looking at their glycosamine and glycosamine. We can measure that in blood as well as urine, and you end up with that elevated dermatan sulfate and heparin sulfate. With the IDS gene, it's at chromosome XQ28. And the tricky part, which we'll talk about in one of our cases, is there's over 625 different mutations or variants that have been reported. And unlike some of the conditions, there's really not a lot of variants that are high frequency or recurring mutations. So there are some conditions where, like to think about Gaucher disease, there's a common variant that you see. And it's seen in a large percentage of affected individuals, whereas in MPS II, you're not seeing that same high prevalence of a recurring variant that allows us to readily interpret what we're seeing for newborn screen. There are some general observations in terms of thinking about genotype-phenotype correlation when you're looking at what variant you have. So missense variants have been seen with the VIR and the attenuated phenotype, whereas the nonsense, the splicing ones, growth rearrangements, deletions, those sorts of things are more associated with a severe phenotype. Germline mosaicism has been reported. That just means that there are times where you can have a mother who has more than one egg cell who that has the change for MPS II, but is not finding it in her blood. And then pseudodeficiencies, that's one of the things that we have come across a lot with newborn screening. And I think that was a bit of a surprise to us as we embarked on newborn screening in the state of Missouri. And with both MPS I and MPS II, what is tricky is you can have variants, and so that will cause a lowered enzyme level in the lab situation, but the patient does not end up going on to develop whatever, whether it's MPS I or MPS II, and a pseudo or false deficiency of that enzyme. And that poses problems when we're trying to interpret a result that we don't have data regarding what that variant has done before. It's not been previously described in the literature. And so that hesitation of knowing what we're looking at, are we looking at a pseudodeficiency, or are we looking at a variant that is known to cause an attenuated or a severe form of MPS II? This is just a slide. We can't have a genetics lecture without showing some kind of pedigree. And so this would be a family where there are multiple individuals who are both carriers of MPS II, as well as multiple affected individuals throughout the generations. So I think the little boy on the bottom right is a little bit trickier to see that he has manifestations because he's not, that old yet. But you can see the two boys on the left, like one looks like is using some kind of cane or walker for assistance. And they have likely orthopedic issues at this point as well. This one I like only because it shows you siblings. And so we're going to talk about treatment in a minute, but patients in A and C, so the first and third columns are the one patient, and then B and D are his younger sibling. And so patient A did not have treatment right away versus patient, the second younger brother was able to start treatment earlier because of the knowledge of having the affected brother. He didn't have to go through that same diagnostic odyssey that his brother went through. But you can see the claw hand, particularly for the first patients in columns A and column C. You can compare and contrast even just looking in that middle row in C and D, and look at the difference in the range of motion between the older brother in column C and the younger brother in column D who got treatment, and the improved range of motion that you can see. And I think that's significant. And you can see differences in their hands as well in terms of just the ability and dexterity that they have in their hands to straighten out their hands to improve movement. So when we have someone who has a known diagnosis of MPS II, what do we do? So we are going to do a bunch of tests to assess where they are really. So we would think about doing an echocardiogram, pulmonary function studies, sleep studies, audiology, eye exams. And so even though I said that they don't have the corneal clouding, that is still part of the evaluation and workup. We will do nerve conduction studies sometimes, and then an MRI and hydrocephalus for spine compression. I have an asterisk to the intubation concerns. I'm going to skip ahead for a second. Because there is risk associated with general anesthesia. And this is something that's talked about frequently within the medical community, where there are concerns for these patients because it's difficult because of all that gag accumulation with that large tongue, with the soft tissue accumulation of the large tonsils and adenoids, it can be really difficult to get a good look down through their airways. And then there's also the concern about hyperextending their neck because of the atlantoaxial instability and the cervicomedullary compression that can be present for these patients. So doing general anesthesia for these patients is something that is not taken lightly, and wanting to make sure that they are at a tertiary care facility and not at a smaller facility that doesn't have the ability to manage the complications that may come up for these patients is something that is really impressed upon these patients, that they need to seek care at larger centers who are familiar with MPS disorders and are familiar with the difficulties with intubating these people. In terms of treatment, some of the more common things you think about is developmental therapy, physical therapy, occupational speech therapy, all of them very important for these children. From a respiratory standpoint, they may need CPAP, they may need to be trached. Carpal tunnel release is something that we see for hernia repair, tonsils and adenoid removal. But you can also see some of these things are surgical, right? And so, in my next slide, I talked about all the difficulties of general anesthesia. So it's, this balancing act of wanting to treat the different things that may need surgery, but balancing that with the risks of anesthesia. And so it's not always easy. We have had patients where the team, from a cardiac standpoint, from an airway standpoint, has chosen not to pursue surgery on the hernia just because of the risks. We felt like the risks outweighed the potential benefits of going in and doing that surgery. So treatment for MPS II the things I talked about before are more of the kind of reacting to the different symptoms. But there is actual medication for MPS II. It's called idursulfase. It was approved by the US FDA in 2006. St. Louis Children's Hospital, Washington University was actually one of the clinical trials sites for that medication. Really quite privileged to work with families who moved here from all over the country to be part of this clinical trial. It does consist of weekly IV infusions. And again, to spend some time for those of you who may not be in the field, this is not something to be taken lightly for these families. These infusions tend to be about 4 hours, which means they're usually here for about 6 because they arrive, they're gonna, we don't have the drug mixed and ready to go just because of the cost of the medication. We don't mix the drug until they're here. And so it may be an hour before the drug gets mixed for them to be able to start treatment. And then if it's a 3 or 4 hour infusion, and then we usually keep them on site for 30 minutes or so afterwards to observe, make sure they're not having allergic reactions. And so it is an investment in time for these individuals to be coming to our facility and to be getting these rather lengthy infusions on a weekly basis. Dosing for the medication is based on weight. So it's 0.5 milligrams per kilogram is how we determine dosing of the medication. And then, so there are the data in terms of what you look at and what you expect to see is positive effects on functional capacity, liver, spleen volumes, and urine GAG levels. It does not cross the blood-brain barrier. So we'll talk more about that in a minute. But there are studies that show delivering intrathecal enzyme it was insufficient in terms of meeting evidence to support continuing on with that study. That was something they were trying to deliver it intrathecally to see if that would help. So when you think about enzyme replacement therapy, the first thing is to realize it's not a cure. Like families and parents are often asking, is this a cure? And it's not a cure. It is a lifelong treatment for these individuals. The outcomes are most favorable if you can start less than 18 months, as evidenced by that, the comparison of those two siblings. It helps to slow the progression of somatic disease. So you're going to see, like I said, those decreased liver and spleen volumes, stable 6-minute. You're going to see a reduction in respiratory infections, hopefully maybe some improvement or at least stabilization in their range of motion, stabilization of cardiac and skeletal disease. And unfortunately, because it does not cross the blood-brain barrier, it does not impact their cognitive concerns. That for the individuals who have the more severe form of the disease, they will continue to regress and have progression of their neurologic concerns. And when we're talking about all of this, I was asked to also speak to the insurance improvement or approval process, and I have some more slides on that. But while I had this slide up, I just wanted to comment, like you can see, the assessments and the things that were documented in the clinical trials. And so insurance companies are now saying, well, in order to approve it, we want to see that your patient is showing and demonstrating improvement. And the hard part is if we're now doing newborn screening and starting someone on treatment when they're young, they may not be walking, and they can't do a 6-minute walk test. And we can't PFTs because they can't follow the instructions, when they're so little to be able to do it. And so it's starting to pose some problems with insurance just because it's a double-edged sword, right? We're starting treatment earlier, but now insurance is balking because we don't have some of the early assessments that they want to be seeing. The other treatment that's available is stem cell transplantation. There's little improvement, they think, with the CNS, but it's limited data at this point. There's some larger studies that shows that it may be a good therapeutic option, but those neurologic outcomes really are modest. And again, to be able to have the most effective treatment for this, you have to do it as early as possible. And so again, speaking to wanting to think about newborn screening. When you look at what's coming down the pipeline, there are gene therapies currently in trial. There are brain penetrant enzyme replacements also in trial. And so it's an exciting time for some of these conditions in terms of what we may be hopefully looking at for the future in terms of options for families. I was also asked just to talk about what is the parental response. And so when you have newborn screening diagnosis, this is overwhelming. I mean, this is a lot of information when they're looking into the eyes of what they perceive as a beautiful, healthy newborn. And so all of this is really difficult for them to digest. They frequently need time to process. Some families seek a second opinion elsewhere. We have been a second opinion for some other people. And I was asked, is there treatment reluctance? And yes and no. I mean, there are some families who are reluctant to pursue treatment because they don't see the evidence, they don't see the need when they have a child who is healthy. And then there are other patients who want their treatment started yesterday because they recognize the concern for this. And so it's a lot of conversations, it's a lot of lengthy discussion when we end up diagnosing kids through newborn screening. In 2000, Forbes published the world's most expensive drugs. 6 of those 9 drugs at that time, it would be a different list now, but at least in 2010, 6 of the 9 drugs were enzyme replacement therapies for lysosomal storage disorders. So I am acutely aware of the cost of these medications because the medication for MPS II was on that list. Costs can be upwards of $300,000 a year because it's weight-based. The cost becomes more expensive the older you get. Insurances do pay for enzyme replacement therapy, including the Medicaid plans. I have found, particularly starting into 2024, there are some insurance plans that now have exclusions for enzyme replacement therapies, which has been problematic. This is the first time that I have personally encountered that, of having several of our patients, not just MPS II, but across the board for lysosomal storage disorders, where the drug companies are, pointing out, because we work with the drug companies in terms of working to get the insurance authorization and then finding that the insurances have carve-outs and exclusions for ERT. The drug companies often have a free drug option. The difficult part of that is they don't have nursing coverage. And so having to figure out how we're going to get nursing paid for when, the family has a carve-out or exclusion for the treatment. When we need to request coverage, we're sending our clinical notes, we're sending lab results, and we're doing this every year. It requires a new authorization every 6 to 12 months. And so every 6 to 12 months, it's sending all the same thing all over again with any updated information. We have often had to see where it does require a peer-to-peer with one of our physicians in the insurance company. And then I was asked, is the process the same for children who are less than a year of age? And it is the same process. It's just there's less data usually to submit for those individuals. I wanted to just mention, because we are talking about genetics, MPS II and pregnancy. So it's not common unless there's a family history. Most women have no idea that they're carriers for this, because traditional prenatal screening is not going to diagnose an MPS disorder. It is on some carrier panels, but it's not something that most families are knowing to be looking for in the first place. And the other hard part with carrier panels is they're not going to report out variants of uncertain significance. They're reporting known disease-causing variants within the gene. And then for families where they have a known family history, pre-implantation genetic testing, CVS, amniocentesis are all available for families in that situation. So I just like to reflect back of where we were prior to newborn screening. So prior to newborn screening, this is an article showing a boy who is about 3 years of age. And so I've bolded a couple of things. So it's saying at 2 years of age, he presented with umbilical and bilateral hernias. At 6 months of age, he had hepatosplenomegaly. 3 years of age, he had stiffness of the hands and developmental delay. He didn't walk until he was well over a year. He didn't start talking until he was 3. And by the time he finally made it into a genetics office, he already had coarsening of the facial features, the hepatosplenomegaly, umbilical hernias, claw hands, and then stiff joints. And at this point, we would start treatment, absolutely, but he already has a lot of the things that aren't going to be reversed very well with treatment. So to speak about Missouri's experience a little bit with MPS II, this was added to the United States Recommended Uniform Screening Panel, what we affectionately call as the RUSP, in August of 2022. And so that's where it was said, we recommend that all states test for this. And so Missouri began our pilot for this in November of 2018. So we were actually ahead of the RUSP. And we went with our go live, where we actually were formally reporting it in 2019. At the start, when we started, we were doing second tier molecular testing, and then we changed doing second tier blood spot gags in 2020, because that was reducing the number of false positives or screen positive cases that we were seeing. And again, just because we're looking at enzyme, it's unable or unlikely to ever detect females who are carriers. And so what's our data? Missouri has had 38 high-risk screens for MPS II. The confirmed cases that we've seen 2 severe, 1 attenuated, 17 variants of uncertain significance. So what does that mean? When we see a variant of uncertain significance, it just means we're not sure. We're not sure if it's just a benign variant that's running through that family, or if it's associated with severe disease, or if it's associated with attenuated disease. We don't have enough information to know. And I'm going to have a case that talks about that a little bit. And then I just wanted to give a nod that Illinois also is one of the few states that is offering MPS II on their newborn screening. So when we have a kiddo with an abnormal newborn screen, we're doing blood spot gag, blood spot gags are provided, and then we're ordering the IDS gene sequencing and deletion duplication. We're doing I2S enzyme analysis. We're doing urine gags, and then we're also doing a different biomarker called non-reducing end assays, or NREs as we call them. And that just gives us some additional information. It complements the information we get from the urine gags, and is thought to be maybe a bit more sensitive. And I couldn't mention this without just talking about the National MPS Society. They are an incredible support to our families, and are a really great resource for individuals who end up ultimately being diagnosed. And we have some wonderful families within the greater St. Louis area that when we have new diagnoses, would be happy to reach out to our families. And so I really enjoy the families that I've gotten to know over the years. So my first case, and I have 2 cases just for some discussion, is a patient who had an abnormal newborn screen. And this is fairly generic, so I didn't feel like the specific numbers are, but an abnormal newborn screen, the enzyme was low, the glycosaminoglycans and the NREs were both consistent with MPS II. And then we found a variant in the IDS gene that's previously been described in the literature. So I think this is obviously a case where the child, we feel everything is consistent with a diagnosis of MPS II. I will say this has not been our experience. This is not what we typically see, but this would be the ideal result, right? Where everything complements each other and looks like MPS II and points towards MPS II. And then depending upon what is known about the variant, we might be discussing stem cell transplant. We might be discussing enzyme replacement therapy. We might be discussing kind of the watch and wait approach of seeing what we know, or seeing, how they tend to progress, rather than jumping into enzyme replacement therapy. And so for these kiddos, I feel like this is a bit more straightforward process than for the second. So this would be someone who their enzyme activity is a little low, and their dermatan sulfate really isn't high. That's essentially normal. And the heparin sulfate is normal. But when you look at the I2S enzyme, that's low. But then the lab we use will often gestalt it for us and say, well, it's below normal, but it's above the range that we observe in patients with MPS II. So we take that into consideration when they tell us that. But then their molecular comes back and it shows a variant of uncertain significance. And so what do you do with that? There's not data in the literature for this variant of uncertain significance to say whether it could be, an attenuated form. It doesn't tell us whether it could be a pseudodeficiency. What we often will do is look to see if there are any male relatives that are available to test. And in this particular case, patient is an only child. The mother's not on speaking terms with her father. She has no no siblings. And so here we are looking at a variant of uncertain significance and really not knowing what we're dealing with. And so in these cases, what we typically tend to do is continue monitoring the patient. There are some cases because their GAGs and their other values have been completely normal, even if we find a variant of uncertain significance, but their enzyme was completely in the normal range, we may opt to not follow them. But for a lot of the patients who have been found to have variants of uncertain significance, we are continuing to monitor them in our clinic just because we do feel like this is all still so new in terms of what we're discovering for these patients, but we obviously would not begin treatment for any of these individuals with a variant uncertain significance without more data. And I think that is my last slide. I just wanted to acknowledge both the Missouri and the Illinois Departments of Health for all that they have done. And then I got some of my slides from one of the physicians that I work with. And that's all. So I'm open to questions at this time. How are we doing on time, Joanne?
Oh, we've got some time. You did good. You did good.
Okay.
I want to thank everybody for introducing themselves in the chat. I do not see any questions in there, but Kira will open up and unmute everybody so that you can ask Linda any questions that you have. Are there anybody that has any questions, or they can put it in the chat box? I know I had one. Oh, Pat's got one. Go ahead, Pat.
My question is, could we have a copy of this PowerPoint?
Yes, we will be sending out the
Sure.
PowerPoint to all the people afterwards.
It's
yes.
an excellent presentation and it's
Thank you.
a good teaching tool. So thank you so much.
Yeah, you're welcome.
My question is, Linda, you were talking about this as a lifelong treatment on the enzyme replacement therapy. Is that weekly or is it
It
less?
is.
It's weekly.
No, it's weekly. It's weekly duration. So for some of our patients, if they have tolerated the treatment well, and I didn't include talking about, I mean, there are risks associated with the treatment. So some of our patients, there's always risks for anaphylactic reactions. They tend to decrease over time. So we usually, at least in our practice, tend to keep patients for about 10 infusions at our center to make sure they're not having reactions. And then we will think about transferring them to home health.
Okay, thank you. We have a question here in the chat. Are you doing additional testing for large deletion due to IDS2?
Yeah, so that's part of our initial testing is we're sending IDS sequencing and del-dup.
Okay. Any other questions? I thought of something else too along the way. When you were mentioning, oh, go ahead. Somebody else have a question?
I do. Hi, this is Tracy Bishop. I'm with the California Newborn Screening Program.
Tracy.
We're actually starting in July or June. No, July, the beginning of July. But anyway, my question is, you gave a slide of tests and, tests that you would do with, a patient you see with symptoms. Do you do any of that with your newborn patients? MRIs, all that stuff? No.
We have not been. We are doing all of the enzyme, the sequencing, the GAGs and the NREs before we jump into assuming that someone's affected.
Yeah, okay. But would you, once you get the sequencing back and, high GAGs, would you do that, or would you, you'd
I mean, well,
MRIs?
then it'd be up to the physician in terms of, what they felt like clinically, what we knew about the variant in terms of what they would recommend. I mean, I will tell you at our center, we haven't had anyone who is looking like a severe form of MPS II diagnosed. So, I'm not from personal firsthand experience, but just kind of what our current protocol is of what we have thought about and what we've developed. Should this happen, because you have to have those plans in place, of course, but it just has not, we haven't had someone who's been presented with a severe form.
Yeah, okay. Yeah, I was just curious. I'm trying to develop our short-term and long-term follow-up forms and trying to decide what I need to put on the short-term because, most of them, within the first couple of months will probably look asymptomatic, right? From everything you said and I've seen. All right. Thanks so much. Yeah, and if there will be copies of the slides, it would be great to have them or a recording of this to share with my team. Thanks so much. Yeah.
Another question on the chat, how have you been successful getting ERT covered for those under 18 months, like Medicaid?
Yeah, so again, I don't have anyone under the age of 18 months. We have started with MPS 2, but for other conditions, it hasn't been an issue. So, and we also, for example, do newborn screening for Pompe disease. And while different, also similar in terms of the progression that you see. And so we certainly will, I mean, the physicians document very clearly that it's a progressive disorder and what the outcome is of being on treatment versus not being on treatment, that we've really not had a problem getting it covered, except for those plans where there is an exclusion. It's more of the renewals, those annual renewals, where the insurance companies are now starting to ask, even from the kiddos who are diagnosed on newborn screening, insurance companies are starting to ask to show the benefit when they were too young to do the 6-minute walk test or PFTs or whatever it is they're asking for.
Any other questions? I don't see any more in the chat. Go
Hey,
ahead.
Joanne, this is Joelle.
Right.
Hi. Thank you so much for your overview, Linda. That was really helpful. I really appreciated seeing the different pictures that you used, especially with the siblings, and just the images I think are really helpful to see the progression and everything. I'm curious, so with the treatment, does the if it slows the progression of skeletal issues, does that delay the facial features also, or is that not something that the treatment will help with?
It's a great question, and I will be honest and say I don't know. I don't know if I've seen data for that to specifically know. It's a great question.
The progression of the youngest child, was there 4 different pictures of that progression of that certain person, and it's like, oh my gosh, at the first picture, I wouldn't have even thought of anything. So it was interesting if they have the treatment, will that appearance be slowed, I guess, the change in the
great question.
Okay, thank you.
Great, Joelle, thanks. Anybody else out there have a question? I thought of something along the way. I know, Linda, you mentioned in one of your slides about the level y'all use for your gag on the newborn screen.
Okay.
Okay. Is that pretty consistent? Did you get that from another state, or did y'all change it at all? Or are other states, the few states that are doing, is that consistent with what other states are using?
I honestly don't know.
Okay.
Tracy, I see you on here. Do you have any, could you help answer that question at all?
Yes. Yeah. I was like, oh, where's my mute button?
Thank you, Tracy.
Yes. Yeah. So we send out our gag testing for that's our second tier test, and we send that to Mayo. So those are Mayo's cutoffs.
So what is your first line of newborn screening, your first tier? What is that one?
Oh, sure. First tier, we're looking at the level of IDS.
Okay.
And the dried blood spots. And then anything that's below a certain level, then we send for second tier.
Okay. Can those be shared with the group, what those levels are?
Sure. For the cutoffs for IDS, is that what you mean?
Yes.
Absolutely. Yes, I can send those to you, Joanne. Would that work?
Sure. Here. And then we can include it with the PowerPoints when we send that out.
Okay. Yep, I can do that.
So your first level, if you have an abnormal or a low IDS, then that one is the second tier, and then that goes to Mayo.
Correct. And we send those dried blood spots to Mayo for second tier testing.
And then your third, well, I guess your third thing would be, then you do the workup for the diagnostic, right, Linda?
Yeah, then they would get referred to one of the sites across the state.
There's a lot of newborn screening people on here. That's why I was wanting to clarify that too. Anybody else, any questions? I think it was just great, your talk, because that one picture, as Joelle was talking about, that showed a child through the years, and that was an untreated child, correct?
I believe so, yeah.
Okay. That's certainly.
I mean, he was clearly before newborn screening.
Right, right, right.
You know, if he's 30 now and we've been doing newborn screening since 2006, he might have been on treatment later. I didn't pay attention to what year that publication was from, but any
Okay.
treatment would not have been when he was a child.
Okay. Some other people on here are wanting to use your slides so that they can take it to their advisory committee too. You know, that would support them implementing newborn screening for MPS 2 in their state. So your slides are gonna move forward throughout the United States to people here that are going to be using it. Any other questions about anything?
And I just want to mention the evaluation, the surveys in the chat.
Yes, yes. I'll go ahead and do a few closing remarks. If someone has any questions along, you know, while I'm doing this, let me know and we can have it at the end. I want to thank Linda for her talk today. And I want to thank all of y'all for attending all 3 sessions. If you did, please complete the evaluation. Gail will be sending out the link. Carol will be too. And if you've attended today, you must complete the evaluation for us to give you award you the free CEUs, and this is for genetic counselors, physicians, assistants, and nurses. And I know Gail put on in the chat the Heartland website. You can certainly watch all 3 sessions there, but you cannot get CEUs unless you attend the session. We will be sending out the PowerPoints. Also, in the evaluation that Gail will be sending out, please share your thoughts about today's session, as well as the 3-part series. Let us know we have no plans for any future newborn screening trainings using ECHO, but if there were, what did you like? What could be improved? What trainings are you needing for your practice? And any other comments that you'd like to share with us. And I want to thank y'all for attending today and hope you have a good rest of your day. We have a minute or two. Are there any other questions that anybody has about MPS 2? We have a new message. Just a second. Let me move down here and see.
They're just thanking you.
Oh, they're just thanking me? Okay. I was wanting to look. Okay. I don't see any other questions. Linda, you've just done a wonderful job. It's been so I've learned so much from your talk. I feel much better about MPS 2 than I did before the presentation. And I've had a chance to review them ahead of time. So even after today's session, it clarified a lot of things for me. I'm sure I will have more questions as time goes on. And I'm certainly probably the audience or the attendees will too, that are not familiar with it, but it's been so good. Thank you so much. I guess we'll close today. And Linda, thank you again. And everyone that's attended, please look out for the evaluation link that will be coming out, and so that you can complete that and get awarded your CEUs. And I appreciate everybody coming.